Welcome to the Medical Staff Voice Live. I'm Dr. Stan Frosweig, Chief Medical Officer at Community Memorial Health System. And I'm joined today by Dr. Chris Kerrigan, Addiction Medicine Specialist. Welcome, Dr. Kerrigan.
Hi, nice to be here.
It's such a pleasure to have you here. We really appreciate you joining us so our medical staff and community can learn more about your practice. In order to do so, we have a few questions that will enlighten us and give us better insight into you and your specialty. So let's start this way. Tell us about yourself. Where are you from? Where did you train? What brought you here?
Sure. I was actually born at West LA Community Hospital in Los Angeles, California. My father's from California. I have a lot of extended family out here. We moved to Massachusetts when I was 3 years old. And then I went to high school in Colorado, and then back to New England for college, and then medical school in Europe, and residency in Montana, fellowship in Nashville, and then back to Southern California about over 30 years later. Finally made it back home.
You've been everywhere.
Been a lot of places. It's been a lot of fun. My hobbies and passions in life are mainly going to the beach. I realized all my vacations were centered around how do I get back to a beach. So, I said, well, why don't I just live on a beach? And Ventura was the perfect place for that. So I can play volleyball and body surf or just read a book on the beach and watch the sunset. And it hasn't gotten old yet. I've been here 9 months.
Well, that sure is a win-win for us. I'll tell you that. That's really amazing. So if you could give our colleagues and our patients and community at large a sense of what is addiction medicine, what do you do, and what kind of special treatments, if any, do you have, and what ages do you treat?
Yeah, sure. So that's actually a really good question that I tried to figure out in fellowship is, what is addiction medicine? I didn't even know when I went to fellowship. How do you define it, right? Cardiology is pretty easy to define, addiction medicine to define. So here is this is not the official definition because there's none that I can find. This is my definition of it. Addiction medicine is the diagnosis and treatment of substance use disorders or complications to alcohol and drug use, which can be divided into three major components. It's treating cravings for drugs and alcohol. It's treating comorbid conditions that lead to drug and alcohol use, which I've found is just about everything. There are no conditions in medicine you can't get some temporary relief from a good dose of stimulant, alcohol, or opiate. We'll short-term treat just about everything. And then the third is pipelining to other either specialties or treatment modalities. So whether that's seeing a psychiatrist or going to AA or a clinical psychologist or an endocrinologist or an immunologist, rheumatologist, pinpointing that as treating it.
Thank you. That's really helpful. I have to admit, the first time I heard you speak, it actually touched my heart because you described addiction in a way I've never heard it before. Usually people have these pejorative attitudes towards treating addiction. And I heard you talk about how the way we should be thinking about it is more so along a biochemical, almost endocrine-like problem. Could you just touch on that?
Sure. You can always compare it, and that's how I think of it primarily, and I really consider it an endocrine disorder, particularly opioid use disorder. And, I would like to give a shout out to Christine Supple, who loves hearing about what opioid use disorder is like diabetes. And we can talk about it again today. But let's look at diabetes. Diabetes, type 2 diabetes, right, comes from eating so many carbohydrates and sugars that you get permanent epigenetic changes to your insulin receptors, which become less effective. Then eventually your pancreas stops making insulin. And depending on the severity of the disease, you can treat it lifestyle at first, and as it progresses, you need higher level of medications, when eventually you just need to give the insulin to replace the insulin that has been torn out. Nobody has an issue with that. It's very concrete, logical, right? Why would anybody drink a soda when we're amputating their feet, right? Why would anybody eat a plate of cookies when they're already full? It doesn't make any sense, right? I've sure done it. But it doesn't make anyone with diabetes to eat added sugar ever. But we still do that. And why do we do that? It's a dopamine pathway response. In the brain. In the brain, yeah. I mean, we as humans evolved to binge eat, have sex, and explore, right? And we have a positive negative feedback loop system in our brain that promotes us to do that. And as anything in the body with a positive negative feedback loop, whether it's your adrenal glands or your thyroid or your parathyroid or your testes, things can go awry and you can have pathology that needs to be treated. And if you look at the majority of diseases that get treated in the hospital, I remember doing hospital admissions, how often do we admit someone that there's no lifestyle component to what they did?
Well said.
If you were a hospitalist and you said, I don't treat people with a behavioral component to their disease, well, then you don't treat COPD or COVID or obesity, hypertension, coronary artery disease. There's varying levels of treatment for it, but very rarely do we admit someone without a behavioral component. It happens, but it's rare. So with diabetes, dopamine pathway disease, varying levels of stages, genetic and environmental component, right? We know if your parents have diabetes, you're more likely to have it. We know lifestyle plays a major role. And more recently, we learned that the adverse childhood event scoring increases your risk of diabetes, right? And why is that? It's because early childhood trauma downregulates your D2 dopamine receptors in your brain.
So you're really saying that those same biochemical changes and cravings that we have for sugar and sweets occur to the addicted individual as well.
Correct. And there's different pathways to dopamine response. But on functional MRIs, there are key findings that are actually found in all substance use disorders or diabetes, that certain D2 dopamine regulators will be downgraded. So when I diagnose someone with diabetes, I encourage lifestyle changes, of course, and I treat with medications. And someone with opioid use disorder, right? What's opioid use disorder? It is heavy opioid use that will cause permanent epigenetic changes to a positive negative feedback loop in your brain, the D2 dopamine receptor. Nothing releases dopamine in nature like opioids do. Not watching a sunset, not having sex, not eating a candy bar, nothing releases like that.
Wow.
And when you have permanent epigenetic changes, you need permanent medication, most likely. And that's why the studies have shown that lifelong treatment with medications is your best shot at success. And if you catch it early, and you do with lifestyle, like someone with an A1C of 6.7, and you say, hey, let's jump all over this, people get better without meds, great. If they need meds, there's no emotion to that. I just treat them with the meds and I do the best to get them better.
That is incredibly enlightening and revealing. I know that you commonly will treat addiction problems with buprenorphine and or Suboxone. Mm-hmm. Is that accurate?
Correct.
Very good. And are there certain things you will not use or will not treat people with that have addiction problems?
Yeah, great question. So always we go down, the evidence base, and we've tried a lot of things. And it's a common question. Why can't you just give me Norco? Because otherwise I'm going to go use drugs. And the answer is very simple. It doesn't improve your chances of sobriety. In the case of opiates, why is that? Inevitably, hydrocodone, oxycodone, heroin, fentanyl, you'll need bigger and bigger doses over time to get the same effect. And medications that have the potential for substance use disorder are because the positive negative feedback loop, again, they have a potential that your brain's going to change, it's going to wear off, and you need higher doses to get the same effect. Important to remember that's the same for Xanax, alcohol, THC. That's what makes them addictive. Buprenorphine doesn't have that component. Wow. Whatever effect you have from buprenorphine now, you'll have the same effect 10 years from now. And buprenorphine was actually developed as a pain medication that was not addictive. And that's actually where it came from first. We started using it later for substance use disorders. But if somebody either has their pain controlled or their cravings controlled, and usually in my clinic's more a matter of controlling cravings, then they're probably going to have cravings control for life, and it's not going to change.
Wow, that's so critical for our medical staff to understand. Where is your office located?
Yeah. I have 3 clinics right now, one at Ashwood in Ventura, one at the Midtown Medical Group, which is my residency teaching clinic in Ventura, and one at the Vineyard Clinic in Oxnard.
And you bring up the residency teaching clinic. I know for a fact you've been involved in propagating your knowledge and our capacity to care for addiction by training other physicians in the use of these very same therapeutic medications.
Yeah.
Thank you for doing that. That's amazing when we can expand our individual impact.
Yeah.
Thank you. Well, I will say we already have an understanding of what your hobbies are, the things you love, the beach and so forth. We're going to lighten this up one more degree.
Sure.
And we have a favorite part of this, and it's called This or That.
Okay.
And so we're going to start by starting a simple one. Dogs or cats?
Dogs.
Perfect. Early bird or night owl?
Night owl.
Time machine or magic wand?
Magic wand. I get in way too much trouble with the time machine. I would end the universe.
Who knows what you would disrupt,
Yeah.
huh? Oh, what's worse, laundry or dishes?
Dishes.
Okay, skydiving or bungee jumping?
I'd say neither, but I'd probably go skydiving because someone else would pull the chute at first. So.
Very good. Ocean or mountains? I think you gave me the latitude.
Yeah, I love mountains, but ocean's number 1, of course.
Perfect. For casual wear, sneakers or sandals?
Sandals.
Nice. Passenger or driver?
Driver.
Yeah. In control.
Yep.
Okay, the fun one here, superpower. Be invisible or read minds?
Be invisible. I don't want to read minds. Oh, man.
That's great.
Although,
Well, that is wonderful. Thank you for tuning in to learn more about Dr. Chris Kerrigan. For more information on all the services and specialties offered at Community Memorial Health System, visit cmhshealth.org and be sure to like and subscribe for more from your community health system. Thank you, Dr. Kerrigan.
thank you.